welcome on this beautiful day. It is finally, I can say it is gorgeous out. It is indeed beautiful. We walked over today. So, how many of you all are patients, have been patients, have family members who have been patients at one point or another? Pretty much everybody, right? So you all understand having really high expectations for your providers, I'm sure. So taking a different perspective, how many of you are clinicians or going to be clinicians at some point? Yes. So you all understand managing those expectations and how sometimes they may be a tad bit unrealistic, or you may see the patient as being difficult, but as a patient, you never want to be seen as the difficult patient, but you definitely have high expectations for your patient, for your providers. So today, we have the pleasure of having our Director of Medical Ethics here to talk with us about managing and working with difficult, challenging patients and their expectations of them and their families. So please join me in welcoming Dr. Mark Swope.
Thank you. Thank you all. Hopefully this will be very practical in talking with patients, in particular as clinicians, and just in everyday life. These techniques have been proven to be effective and should hopefully help in communication. So we know from studies, from the data, that there's estimated between 10 and 65% of patients are considered difficult by their treating physicians. Now we have to keep in mind that, of course, these are not patients submitting this data, but these are physicians that are giving this and saying. So we know that it's a very widespread problem. So what is a difficult patient? Well, research on the difficult patient generally defines a problem exclusively, like I said, from a physician's perspective. And difficult patients are typically described as those who raise negative feelings within a clinician, presumably from behaviors that are deemed inappropriate in treatment setting. So the clinician, feels frustrated, there's anxiety, there's guilt, or dislike interactions with the patient. It frames, what we know from research in the casual and the dysfunctional dynamic between sometimes the patient and the clinician. So there's also a laundry list of a difficult patient. And what's that? Someone who makes repeated visits without apparent medical benefit, patients who do not seem to want to get well, patients who engage in power struggles, patients who focus on issues seemingly unrelated to medical care. We know that difficult patients can also be demanding, disruptive, attention-seeking, annoying, manipulative behavior. So many physicians report feeling at a loss of how to deal with these particular patients, how to manage them, because it's quite challenging, right? Whenever we come across somebody who is difficult to deal with. So what do we do? Well, as a result, physicians will sometimes, unfortunately, I'll get called, refuse, can I refuse to treat someone? Can I dismiss them from my practice? What can I do? What am I ethically and legally bound to do? So when a clinician relationship is severed, it's hard to escape the lingering feelings, right? These lingering feelings are very real for a physician. There's ill will, there's mistrust, there's resentment, there's job dissatisfaction. So it's not a good feeling for physicians to be in a situation like that. So if a breach in the doctor-patient relationships can be avoided, and good rapport can be reestablished, it's better for all. Not only for the patient, but also for the physician themselves. Because we know sometimes, if we happen to sometimes, and it's appropriate, maybe to dismiss a patient from our practice. But there's still that unresolved feeling. There's still that, perhaps resentment. There's still, that feeling of tension and all that ill will that sort of caused that relationship, to kind of sever in a very negative way. Mediators are very good at conflict management. And the approach to conflict and techniques that they use to resolve has been identified as potentially useful for physicians having negative and challenging patients. And in the absence of substantial investment of provider time to master mediation techniques, I'd like to offer some benefits that might help in this relationship. So I want to consider using a toolbox and 7 tools that we can use to help in management of conflict. Number 1, and I'm going to go through these individually, but just to name them, view as a syndrome. Difficult people, difficult patients should be viewed as a syndrome and not as a species, okay? Number 2, finding the source of the anger. That helps dramatically in the conflict resolution. De-escalating or escalating in seconds. Just the acknowledgement. We know in less than a minute we can escalate or de-escalate a situation very quickly, right? And I'll give examples in that. Don't call out inappropriate behavior. This might be a little not what you're used to, but it's one suggestion that has been proven to be effective. Neutrality, that can be difficult, being a physician and being a part of the conflict, but I'll talk about that in a second. Naming the concern, a very important concept and something to recognize, and sincere apology or consolation, which can go a long way. So difficult patients should be viewed as a syndrome, not as a species. So all of us, right, or most of us, not me of course, but most of us can become difficult on any given situation and on the right conditions. So if negative patients' interactions are understood to be merely circumstantial, right, we know that they can also be regarded as amendable to change. And that's what we want to strive for, to be amendable to change. So we have to kind of think of it in those terms. It's not that it's, he's always difficult. Well, like I said, any given circumstance, we can certainly become difficult ourselves. Number 2, anger is reactive emotion. So the key is finding its source, right? We know from our own life experience that getting to what is really, the anger, the emotion, finding the source of it is really so helpful in amending a resolution. Because anger can spark all sorts of things, and we get in these conflicts and we get in these conversations with our family, our partners, our spouses, which have nothing to do with really the underlying anger issue. And people's perception of being wrong or offended or harmed. So we need to find the source of anger and address the underlying issue. The symptoms of rude, aggressive, insulting behavior will usually resolve automatically. Number 3, like I said, it takes mere seconds to either escalate or de-escalate a brewing conflict. If somebody cuts us off on the road, right? You wouldn't want to give them the middle finger, right? You wouldn't want to do that. Not that I've ever done that in my life. But we know how we can escalate a situation just in seconds. And we know how we can de-escalate the situation also. And that's what I'm going to talk about in using our tools. So anger can be abated in less than a minute. Number 4, calling someone out for bad behavior will inevitably make matters worse. If we need to be mindful of ignoring the verbal package which the message is being delivered. Because somebody who, if we get anger and we're using foul language, we're dropping the F-bomb, we're doing this, we're doing that, if we right away ask that person, say, I really don't appreciate that type of language, we're already kind of separating ourselves to an amendable situation. So if we can separate ourselves and ignore the verbal package in which a message is being delivered, that can certainly help in our approach. Exercising neutrality. This again can be very difficult when we're in the conversation with the person and trying to amend the situation. But it's helpful to realize that when the temperature is very high, We need to reduce it before we defend our own clinical practice, our colleagues, or institutions. Right away, we become very defensive. We say, no, they're just trying to do their jobs. Right away, no. I recommend that we don't do that, that we kind of, wait until the temperature is more reduced before we talk about an explanation of why somebody waited, 2 hours in our waiting room. Naming the concern. One example, to the patient yelling and cursing for the 2-hour wait, somebody comes in and says, I'm freaking tired, I had to wait 2 hours, in order to come in and to see you. We recognize that. We say, the delay in this appointment has wasted an enormous amount of your time. And it's very frustrating to wait. But if you dismiss it, or if you ignore the concern by saying, well, let's hear, or, well, I'm here now, let's get this on with, You're here to see me, let's go. That's not necessarily a good approach that I would recommend. But certainly naming the concern is important in any sort of adversary situation. Identifying it, very, very helpful. And I also suggest that we don't use comparisons. Somebody says, gee, I waited 2 hours in the waiting room. They say, oh yeah, I know how that feels, Gosh, I was 15 minutes at the gas pump this morning. No, we don't want to do that. We don't want to compare something. End of life issues. Somebody says, I'm really having a hard time, my mom passing. We say, yeah, I know how you feel. That's awful. My dog died last year and I still can't get over that. No, don't try to compare. Don't use comparisons, and name the concern, which certainly demonstrates, more that you're willing to work with this person. Number 7, sincere apology or expression of consolation can go in a long way in diffusing a tense interaction. So the apology, I'm sorry for, I'm sorry that, are two of the most important tools, I think, in a person's arsenal. So physicians and clinicians, and just people in general, sometimes we're reluctant, especially physicians, to use them for fear of liability. But most of the time, we're not talking about a liability issue. We're not talking about a malpractice issue. And those harmless words can mean a great deal to people. So we need to use an apology when there's even a slight culpability and the expression of consolation, when the circumstance is clearly beyond your control. In a long wait time, we could say, for example, I'm sorry that you had to wait. We had an unexpected emergency. Now I'd like to talk a little bit about diagnostic listening. I'd like to talk about some techniques that we can use. So, one of the first techniques is distilling the core content of the person's narrative, restating it back to them thematically, back to the speaker. It's very important when we're in dialogue with people that we restate it back thematically. Number 1, it gives credibility that you're listening. Number 2, it helps that person to know that you're understanding and what they're saying. And that's a good point too, to when you're restating it back, is to clarify issues. So it's I think, a very good technique to use. It establishes trust, and it gathers the information needed then to set the agenda for the dialogue, for the conversation after. So when somebody comes into the office, they go off on this story, they want to tell you what's going on, and you might interrupt, you might wait till they finish whatever is appropriate, but certainly you want to gather the information so that you can set the agenda for the conversation after. It's very different than sympathetic listening, allowing a person just to vent, okay? Because we want to make sure that we're hearing and having that trust. So, some of the steps in diagnostic listening. Listening analytically to the speaker's testimonial, trying to capture the essential themes, the worries, the complaints, and the perspective. Then we want to check our own comprehension by stating the content back to the speaker. And then number 3, we want to ask for clarification if you miss essential points, right? You don't want to miss anything, so, listening and to making sure when you state it back so you don't miss anything or even misunderstand. I like to recommend taking notes. I think it's a very effective technique in listening because it tells the person that, that it demonstrates the importance of them telling you what's going on. The speaker's narrative is very important, and I think it shows some credibility there. And it lowers the risk that you'll miss essential points if you do take notes. And this can be a little touchy, and people might be like, well, what are you going to do with those notes? Oh, my notes are just for me. They're just so that I hear and make sure I understand what you're telling me. And I don't want to miss anything, of what's important to you. And I'm going to throw them in the bin that, is shredded or whatever for confidentiality. Or maybe or maybe insisting if they're that uncomfortable with you taking notes, saying, well, I don't have to take notes, but I was just going to, so I didn't want to miss anything. So here's an example. So in the 15 years I've been a nurse, I have never seen behavior that is so atrocious. It's appalling. The kind of things they say out in the hall, in earshot of other patients, cursing, shouting at my staff. When the nurses go into the room, they crowd around the bed, impeding our ability to care for Mrs. Jones. They complain about everything from the food to the way the IV is placed to the way we change the bed. My nurses should not have to take their verbal abuse. So what are the kind of things that you're hearing from this? What do you think? What are some of the things you might want to say to this nurse?
It sounds like you feel your staff is very frustrated.
Mm-hmm.
Maybe I might ask a few more questions, like, can you tell me more about what your concerns are and how I can help you?
Exactly, identifying your concerns, making sure you understand exactly what she's talking about. Sometimes we use general language and we're not quite sure. Don't hesitate to ask that person to clarify and to give you more information. So here's example number 2. My mother has been very consistent throughout the course of her ALS that she wants everything done. From the beginning, she said she would endure any procedure regardless of pain to get more time. I am honoring her wishes, and these doctors are painting me as a bad daughter and as a bad person. They wouldn't want to live like this. It doesn't matter. I hate the way they treat me, like I'm some religious fanatic. The constant guilt trip they lay on me, it has to stop. Again, what are some of the diagnostic listening that we want to check in with this particular person telling you this?
How could you lift up the part about painting me as a bad daughter? How could you reflect back to that person and try to get underneath that to maybe see if there's something that could be...
Just very bluntly asking, say, what do you think they mean by you're saying being a bad daughter? What does that mean to you? What's a bad daughter? What's your idea? What do you mean or feel that they're making you feel like a bad daughter? So, what we're going to do now is we're going to work with a partner, and Deb is going to pass out a case, and the one person can just read what's on the paper, the case, and the other person is going to reflect of what they heard back from them. So we'll just do this for 4 minutes.
Okay, I'll read first.
Recently, you are an 18-year-old single who was recently immigrated to the United States. You work in a much celebrating birthday week. You gave birth to see your baby live. So you the doctor for the doctor first told you about the issue you did not understand what that means. Your medicine was complicated conditions. Your first language. These doctors intimidate you first, and that makes it worse. Your doctors intimidate you. You are sure they were down. You are worried about Linda. They say she works a lot. She says she needs it something. She has no idea whatever that is. And that if she doesn't get it, she'll live nearly an hour away from the hospital. You are not sure if you perform the appropriate care for her. That's why the doctor says she needs it all the time. She needs it all the time. Well, it's 18 months. They say that she needs it. She would watch her while you work and she needs all this care. How will you keep your job? If you lose your job, how will you care? How will you pay for all this? The doctors don't even seem to agree about how you don't manage your family here. You feel helpless, doctors know it's work, you just want to take your baby home. You don't have a support system. You feel helpless or have no support system. You just want to take your baby home or you don't want to care for it. So,
And so,
shut up. Don't work with your problems. 18-year-olds. So it's but why she needs as a feature of the language barrier if she doesn't.
Using our listening skills, what are some of the things that we want to be reflective in this person and in their dialogue with Travis King?
I think we definitely want to acknowledge that we hear his concerns about his religion and we honor his religious views.
Right, absolutely. There is no right or wrong answers here, by the way, so, but good. What other concerns does Travis have here? So sometimes it doesn't hurt to ask, about the religious, right? And if we don't understand something, religion can mean a lot of different things. A miracle can mean a lot of different things, When we talk about miracles, somebody says, I'm expecting, or, we want mom to have, we're expecting a miracle. What does that mean? A miracle for what? We know that most people do believe in miracles. Most religions in the practice believe in miracles. People believe in miracles. Even though a lot of people don't practice a particular faith, the percentage of Americans, I believe it's in the 70s, believe in miracles. So when that's thrown out to us, well, I'm expecting a miracle, that can mean a lot of different things. So we want to clarify that. What do you mean by a miracle? Mom will be cured of her cancer. Mom will have a peaceful death. Mom will be able to eat. Mom will be able to walk. What do you expect out of the miracle? So So if we look at our second, Maria Gomez, there's a lot certainly going on with this 18-year-old woman. Again, clarification, repeating it back to her, asking for clarification, making sure. What are some of the issues for Maria?
This is 18 and 11.
Major concern, big concern, right? She's very fearful of that.
Language barrier?
Language barrier.
Doctors all aren't on the same page.
Right, there's not consistency there.
Just a lack of resources and support.
So there's certainly a lot of different issues. We want to be mindful of making sure, again, that we don't understand something, we want to ask for clarification. So I want to talk real briefly about agenda setting. So in our dialogue. So we know that complex or heated conversations tend to meander back and forth between topics and concerns. Unproductive, and it causes conversation fatigue. We know sometimes, conversations can go on and on and on and on, and just be all over the place. So it's very important for us to, when we're listening to somebody in dialogue, to be able to project and to come up with an agenda that's going to be effective. So it's imperative that we focus the agenda, that it's created from the synthesis of the concerns that we hear in our dialogue. So by using our diagnostic listening, we want to make sure that we focus the agenda and address those concerns when we start, the conversation. So that agenda is confirmed with the stakeholders to test for accuracy and thoroughness. So there's some steps. So from the concerns generated from the diagnostic listening, we create a laundry list, right, of issues from each of the stakeholders. So we see Maria, we hear all this from Maria, and as she's talking, we're jotting down, we're organizing in the broad themes, so that we have an agenda for discussion. We confirm accuracy and thoroughness with our stakeholders, right? Is this what you meant? Do I have this correct? Are you afraid that, you're alone? Do you have any other support? Am I hearing this correctly? And you're going to try to get your agenda for your dialogue. So here's the example that we used earlier in the 15 years of the nurse, right? So here's a nursing staff agenda that you might reflect back on that dialogue. So the concerns. What was the nurse's concerns? That there were family concerns about the quality of patient care. That the nurse also stated the difficulty in caring for the patient when the family is present in the room. Another agenda item to address would be to the perception of verbal abuse of nurses by the family. And fourth, the type, the volume, the content of the conversation in public spaces. When we looked at our agenda setting, when we look at example 2 for agenda setting, when the mom with ALS and being the bad daughter. So for agenda setting, for the daughter's agenda, we might want to address the mother's wishes as understood by the daughter. The values of the clinical staff versus the values of the daughter and the mother, as somebody had mentioned. The perception of ill treatment by the clinical staff, and a care plan moving forward. So risks to effective communication. Some risks that I like to talk about, just 2, are ground rules that don't work and decorum bias. So what do I mean by ground rules? Ground rules, by believing that a set of prescribed rules, like no interrupting, no swearing, no yelling, will prevent bad conversational behavior, is like believing that abstinence rules will prevent premarital sex, right? You're setting people up to fail already, and you say, no bad yelling, no swearing. We're already setting people up for failure. So they only work for people who are not going to break the rules, technically, in the first place, right? So ground rules harm your credibility as a facilitator and undermine trust. So say someone raises a voice or uses a swear word. If you call the person out, you've shamed that person. You've already lost trust. You've made that person become the bad guy, right? So if you don't call the person out, well then you've shown, your ground words are really just hot air anyway, and you really look kind of ineffective. So the belief that polite language, when you're in a conversation, good manners, good behavior, foul language, impolite behavior equals bad character, that's not true, right? We've all somehow gotten into those conversations where, we weren't always the most polite, we didn't always have the best language skills, and whatever might be the situation. But, so in decorum bias, nasty, demeaning, insulting things can be said with polite language, as we know. So here's two comics, I think, that illustrate people being polite, but yet being kind of condescending in a way. That dress is great. It really hides your tummy, and it's amazing. How do you do it? Fade in the background, and you go unnoticed, like you don't even exist. Well, it was super to chat. It's so nice the way you make me feel so smart when you talk. But sorry, I was using this time to think about something useful. So we need to try to look past the tone, the volume, and form of what people say is stressful in a very crisis situation. So I was talking about a miracle and the possibility of somebody saying that they're expecting a miracle. So we know from national surveys that 79% believe miracles still occur today. 57% believe that divine intervention can save a person from death, even when the physician feels that death is imminent. Where do they get that? Where do we get it? From TV. Most people, who code, we know, statistics show they survive. There's that unrealistic expectation. And sometimes people will use the sense of a miracle for a couple purposes. Maybe one, exerting power. It kind of gives them power when they feel powerless. When you tell them, this is the medical condition, unfortunately, this is the way that we see this going, and you feel so powerless, the only thing, that can help is to say, well, a miracle is going to happen. It could also be a venue for someone to display their long-held faith, which in turn will result in a miracle cure. So understanding miracle invocation. So a miracle is really seen as an expression of hope that a fortuitous event may occur. Miraculous recoveries. As I said, we've seen them in media, entertainment. And it may mean something to different people. May hear a patient undergoing chemotherapy saying, it would be a miracle if I could just keep my lunch down. Or a surrogate saying it would be 1 in a million shot if this drug were to cure my mother's cancer. So we might want to have a conversation and certainly get pastoral care involved if we feel uncomfortable with doing this, but we might want to say in the conversation when people invoke a miracle or expect a miracle, might want to say your religion is very important to you. That's clear, and I respect that. Can you tell me about the religious beliefs about your mother, right? We want to sort of refocus the conversation from the person, the surrogate, to the actual patient and the actual person's medical condition. So after this introduction, questions such as, did your mother have a relationship with her church or her synagogue? And what would she say about miracles? After conversing about the patient's views on miracles, should explain the difference between deciding for oneself and making medical decisions as a surrogate. So say, for example, being a surrogate means that you focus on what the patient's idea of good care is. This means putting yourself in another person's shoes, right? We want surrogates to make decisions based upon their loved one or their friend, their family member, not exactly what they would want, but certainly upon the wishes of their loved one. And so we need to refocus sometimes those conversations. And do you think that, that you'll be able to do that as a surrogate? So the team may work with the invocator in our community to reestablish agreed upon time limit trials. Very important in healthcare giving time limits. And no matter what circumstance we find ourselves in, time limits can be very, very helpful so that we have a plan of action. So we found this practice that it promotes honest dialogue about the consequences of specific interventions, whether the patient is improving or declining. And it creates conversations which surround continuing or discontinuing supportive measures, cumulative and unsurprising. So it's likely that the invocator conceives a distinction between the living and the dead. So the clinician may say, I'm going to ask you a hard question, but one I thought about quite a bit. What will the patients or dying or death look like? You know, moving beyond what the person and claiming that they want a miracle, again, what do you see or how do you project the person's dying? Again, when we feel very uncomfortable in having these conversations, certainly we want to make sure that we involve pastoral care or religious leaders in moving forward. So again, what does people mean by dying? And what do you think death looks like? You know, we all think it looks different for everybody. Some people feel they see themselves dying in their own home. Some people see them dying themselves maybe perhaps in a hospital. Some people don't even know what that would mean or even project or look like. But I think in the end, and when we use our tools, when we look and have these conversations, these hard conversations, there's certainly tools that we can use to help us to move things along, to making sure that we're understanding people by reflecting what they're saying to us, and creating an atmosphere of trust. Hopefully this was a little helpful in our talk this morning or afternoon, but I thank you for your attention, and I open it up to any questions that you might have or things that were said.
I have a question if you would, you know, I've always kind of operated under what you've said in terms of if a patient is getting a little heated, maybe yelling, maybe cursing, I've kind of let it go and just work through the issues and acknowledge that they're angry and how can we work through this. But then I wonder if a patient actually starts calling you bad names or saying, you know, derogatory things to you, not just the team, or I'm frustrated, or this is effing wrong, or
Right.
you are A and you are A. I feel like then it may be, you know, more important for us to address that.
The conference is now in talk mode.
What are your thoughts about that? Like,
Again, I think you need to look beyond, you know, the tone that it's given. It's very hard for us to do it because we want to be reactive. So if somebody says something hurtful to us, right? And we all do it, right, to our partners or spouses, or, you know, we'll say something very mean. You know, I don't effing care what you think, you know, or, you know, you'll say things that are reactive and it kind of gets heated. If we look beyond the tone that it's given, which is very hard, unless it becomes like a threatening situation, okay, that's a totally different situation. If you really feel that the heated argument is escalating to a point where you feel where your safety is an issue, then you need to, you know, do something to, you know, halt that and get, you know, security involved or something like that. But when people are just, a lot of times, you know, who hasn't dropped the F-bomb or who hasn't said something bad or nasty to somebody out of anger or hurt or in a heated dialogue. So even when we're talking to our spouses or partners and people and clinicians and clinic, you know, we need to really try to look beyond that. And it can be very offensive, right? And that's the whole point, is that we throw these things out, but that's not the underlying issue, you know, as you know. So it's hard and difficult, you know, passing the tone and the volume and what people say, because we've all been there, we all say hurtful things, and that's not the true us. but we do so in emotion. We do so as a reactive measure. You're going to hurt me, say something nasty, I'm going to say something nasty back to you. You cut me off, I'm going to give you the finger in traffic or whatever it might be. So in the moment, the heat of the moment, and I feel strongly that too, calling people out for that, it might be different if we're dealing with our children and if they start using inappropriate language, you might want to say, hey, let's stop that for a second and think about what we're saying. But when you do it with adults, you're already sort of putting the playing field, that you're above them, and that's not really the issue anyway. You want to get to what's causing that anger. Any other thoughts or comments? Thank you all.
Yes, thank you so much, Dr. Swope. I think it's important for us all to remember that we are seeing these patients at their very worst when they are, they are suffering either because they are struggling with something here or their family members are struggling with something. And so we automatically are in a position that is higher than them, and just emphasizing that or making that clear to them is just going to further fuel the situation. So I appreciate, and we appreciate everything you all do as clinicians, and thank you for all of your efforts in tolerating and dealing with them and trying to make the best out of a bad situation for them, because that's why we're here.
Thank you.
Thank you so much, Dr. Swope, and I hope you enjoy the rest of your day. And this is